So
Welcome,
to see
welcome.
you.
Good to see you. So let's just kick off. I'll reintroduce myself, Dr. King-Mullins, also known as Dr. Tushy Touchup as my newer name, but I'm a colorectal surgeon, and you and I have been friends for a couple of years
A
now.
while.
Yeah, I know. We've shared lots of patients, and I feel like on a regular basis, you and I learn from each other, and we'll text while we're in the middle of seeing patients. But for those of you who are watching us now, the best way for me to describe, pelvic floor physical therapy, and Dr. McGowan will introduce herself and give a little bit more detail. But when I'm employing a pelvic floor physical therapist to help me take care of a patient, and I'll use the best example to use is like a woman who has delivered a child. And there's so much that goes into that. There's so much of a physiologic and physical change, right? When
Yeah.
you are having a baby, your whole pelvis has to open up and shift and change. And so think about it like if you have surgery on your hip or any other joint, there's a major physical change that happens. And most times after that surgery or procedure, you're referred to physical therapy for strength training and reintroduction, how to utilize your new normal.
Mm.
And so when we talk about pelvic floor physical therapy, people are like, huh? What? They're going to test what? They're going to touch what? And so, so it's a delicate conversation to have. So I'm going to turn it over to Dr. McGowan for her to introduce herself, her practice, and just start out with like some of the basics of what pelvic floor physical therapy is before we, take a dive into some of these questions that we want to answer.
Awesome. Well, thank you for your patience. I'm Dr. Jennifer McGowan. I'm a physical therapist and I own Regenerate Physiotherapy, which is a niche pelvic physical therapy clinic south of Atlanta. The clinic's been open for 8 years. I was an orthopedic PT for 8 years, 10 years prior to that, and realized how many people did not have access to pelvic floor therapy south of Atlanta. So I also had given birth to 4 children, and the most recent ones were twins, and that kind of rocked my body just a little bit, and knew that it would just be hard to commute to the city to try to see someone after giving birth for pelvic floor therapy. Once I entered into this whole world of pelvic health, I realized there are so many people underserved with pelvic health issues in general. So that's not just postpartum or perinatal, but also women who have prolapse, leakage, vestibulodynia, pelvic pain. We help men here in the clinic as well. So it's become a growing clinic, so I've been able to hire a couple clinicians, and we love the pelvic floor. We love working with Dr. King-Mullins. There are not many colorectal surgeons, so we're so happy that she's down this way because there aren't a lot south of Atlanta. Pelvic floor therapy is more than kegels, so I'm always going to start off and say, people call and they're like, so is this just kegels? No, that's one aspect to the pelvic floor, but we always say the pelvic floor is, 5 S's. And so one of the things that the pelvic floor does that I think a lot of people don't consider is it helps stabilize the spine and pelvis. So it's a core stabilizer. So it can be problematic if you've got chronic low back or hip pain. So it's a core muscle in your pelvic floor that not only lifts and does the Kegel part, but also relaxes and helps with comfortable bowel movements, emptying your bladder, and sexual health and delivering babies. And so we are helping assess not only what's going on in the pelvic floor in our sessions, but we're also looking at what's going outside of the pelvis, so things in the abdominal wall, the low back. And so pelvic floor therapy is just a specialty in physical therapy. And in PT school, we do not get trained a lot in pelvic health. So beyond our doctoral education, we go through extensive training to learn how to treat the pelvic floor. Does that cover the question? Because I can start going
Yes.
down rabbit holes.
Definitely, definitely. Trust me,
Yeah,
these can be all day conversations.
yeah.
And so it's kind of one of those things, right? When me as a colorectal surgeon, I do surgery, and yes, there's a lot of education and prevention that I deal with. But there's some things that I just can't fix. So, I deal with the realm of if there's some sort of anatomic abnormality or defect. And so what our pelvic floor physical therapy specialist like Dr. McGowan deals with is a lot of more of the physiological defects that, just cutting and putting things back together. won't repair. And I will often encounter patients who have pelvic floor dysfunction who say,
Yeah.
"Oh yeah, I had physical therapy or I had this and that." And so I have to like ask them probing questions, and it's an uncomfortable area. No one likes to talk about it. We talk about having kids and all that stuff that comes with it all the time, but we don't talk about the nitty-gritty. And
Mm-mm.
so I have to ask patients who tell me that they've had pelvic floor physical therapy before, and I literally say, did they do a pelvic exam? Did they do a physical exam in which they may have inserted a finger in the vagina or the rectum? And if they tell me no, I stop and say, you did not have pelvic floor physical therapy.
Mm-mm.
So, Dr. McGowan, if you can just kind of open up a little bit of the discussion on, because they're fearful when I'm sending someone over
Yeah.
to do such an invasive exam, but, what does a basic examination encompass, and what can you detect from that exam, and how does that help you treat a patient?
Yeah, yeah. Great question. So, what we do here in the clinic is, I was saying earlier, we do a full body assessment. So, most pelvic floor therapy sessions are hour in length. So, of course, we want to talk about what's going on. And oftentimes, when we're working with Dr. King-Mullins, it's going to be not only constipation, hemorrhoids, or prolapse repair. People are going to also have other symptoms going on the pelvic floor. We talk about sexual health in the clinic. We talk about bladder health. We talk about any chronic hip or low back pain. So a lot of talking. That's a one-on-one treatment room, so it's private. It's not a curtain. You've got a closed room here that's quite roomy. And then we have like just a standard treatment table. It's like kind of like a massage table. It's not a gynecological table. It's not the tables that Dr. King-Mullins uses. They're like a massage table. And what we do is first a full body assessment. I'm going to watch you move, watch you breathe. So it's just clothes on and we're moving. And then we then offer, it's always with consent. Is it okay if we go ahead and do a pelvic floor muscle evaluation? And that's different than your pelvic exam at the OBGYN because we don't typically have a speculum and we don't have stirrups. I always say we're not tented between your legs and the curtain and the sheet there, but instead it's a gloved digital exam. And if you've seen Dr. King-Mullins and she's referring you over, it's a little bit lengthier because we are actually palpating the anatomy with one finger. And so typically I tell clients when I'm explaining it here in this session, it's with your consent. So I'm going to go ahead and say, I'm going to insert my finger at the introitus and we talk through it. Is this okay? Yes. And then we're always asking when we move because what we typically are helping with is any specific pain. So if you have pain on specific pelvic floor muscles, we want to know, is it the muscle that's dysfunctional? Are there nerves that are irritating the pelvic floor? So it's that intravaginal assessment for women. And so that's typically done on your back, and then we sit by your side to do that. And then for intrarectal assessment, which we do here in the clinic, of course, only men can get that for internal. We do that typically in side lying or lying on your stomach. And again, we don't push through pain. There's no discomfort. If it's uncomfortable, we just stop. And then the external portion, of course, we're looking at, can you do a kegel? Can you relax? Can you bear down? Yeah, I didn't just go more in detail to questions that Dr. King-Mullins may be asking because we've got that time. Because we want to know what's the function of those muscles versus an anatomical issue. Like if we see a hemorrhoid that's severe, like that is, we can help with symptoms, but that is in a prolapse. I don't know more about prolapse, but that's like, we can help with symptoms, but that's Dr. King-Mullins is doing the structural fix and we're helping you function and
Yeah.
feel good in your pelvic floor. Is that
Yeah.
concise enough?
No, that was great. That was a
Yeah.
perfect answer. So I'm just going to step back and welcome anybody who's just joining in to our Love Below, the second in our series. Today we're talking with Dr. Jennifer McGowan of Regenerate Physiotherapy about pelvic floor physical therapy, because for some people this is a brand new world. Um, and so, when we talk about the a lot of times when I have conversations with patients about some of their complaints, it may be constipation or difficulty with bowel movements. So first and foremost, people a lot of times will show up and just say, "Hey, I have constipation." And
Yeah.
so my first question to them is to really elucidate, what do you mean by constipation? Like, does that mean you're just not going as frequently as you like? Does that mean that you just don't even have the urge to have a bowel movement? Or does it mean like, hey, I have the urge to have a bowel movement, but when it's time for me to sit down and go, I can't evacuate, I can't get it out. Those are very distinct and different things. And so we have to sort that out. And so when they fast forward, there's like, yeah, no, I feel like it's time for me to go. When I sit down, it can't get it out, or I have to push, 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 or I have to do what's called splinting. I have to support my pelvis. And that's when I break out the fingers, right? So the pelvic floor is, I always use my little hammock uh, um, analogy. So the sides of the hammock are attached to the trees, which are the side bones of the pelvis. And then the hammock has three holes in it for women, two for men. So, our bladder structures for the women, the vaginal structures, and for everybody, the rectal structures have to go through these holes. And so if over time those muscles weaken or change or get damaged and that hammock starts to sag, when it sags, those holes open and things start protruding through, those muscles aren't as strong. And so that therein lies the complexity of just saying, hey, maybe you're saying you have constipation, and maybe that's the only thing you're mentioning to me because you think that's the only thing that matters to me. So it's my responsibility to then ask about, pain with intercourse or difficulty with urinating, maintaining or starting stream. So I understand, do we have issues with the pelvic floor as a whole? So I need to refer you to urology or gynecology, pelvic floor rehab. But can you elucidate a little bit about how pelvic floor and constipation, or pelvic outlet obstruction, as we sometimes will refer to it, what are the links there?
Yeah, so the first thing is, again, we get a little more time in our sessions, but we'll have clients come in and they think they're doing a Kegel, but they're bearing down. Or they think that they're doing the opposite. They may think they're bearing down, but they're doing a Kegel. So dyssynergia, said the word right, that discoordination in the pelvic floor. So if you, and the thing with what Dr. King-Mullins is talking about is it takes a lot of time for prolapse symptom. Prolapse, which maybe we'll go into or not, but that doesn't typically suddenly happen. It's that your symptoms come on suddenly, but it's been through time. And so, which say you strain a lot. And what we're finding in the pelvic floor is we give pelvic floor muscles strength. We grade it here in physical therapy, 0 through 5. But now what we're thinking is range of motion in the pelvic floor. Of course, women's health research is so far behind, but some people have great range, or what we call they can lift and lower really well. Some people don't. How was birth for you? But if you're constipated, which there's a lot of factors that go into that, stress, diet. I know Dr. King-Mullins and I cover the similar things, but if you're straining and your consistency is not good, but your pelvic floor, maybe you're bearing down way more than you even know, that can put you at risk for creating more of a prolapse, which can then also create having a comfortable bowel movement or complete bowel movement freely. So some people have a restricted pelvic floor, so pelvic floor that I say lives on the third floor, and they just live there all day long, and then they try to bear down, but they can't, and now that can become painful. And so I think the function of the pelvic floor muscles, specifically the pelvic floor muscles of constipation, knowing what kind of pelvic floor you've got, which is hard to self-assess, is really important.
Yeah, great. Follow up with that because again, there's so many aspects to it. There's structural versus functional, and so that's what we have to figure out
Yeah.
um, to try to help people move forward. And so, um, can you explain a little bit about just kind of some of the high level basics about the pelvic floor anatomy and how that impacts the ability to, have a bowel movement or to urinate, and any issues with, even potentially sexual, or intimacy concerns.
Yeah, there's layers to the pelvic floor. I do have my pelvis sitting here. Should I show people?
Sure. Listen, pictures
I've always
worth a
got my
thousand
props.
words.
Got my props all the time because
I
hands
know.
are
I'm
great,
always
but
using my hand. I'm like, she's
um,
fancy.
so 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 there's just layers to the pelvic floor. There's three major layers, and this is that external layer. Then this is, so the first layer we call that, which does encompass the sphincter muscle here too. And then we've got the third layer, so it's your deep layer of muscles there. And then in between our connective tissue, so that's our kind of our second layer. And so I'm like, oh my gosh, the vulva fell off. Hang on.
Oh no.
So again, I think that when it comes to all the dysfunction that can happen with, you mentioned painful intercourse, so I want to make sure intercourse, bowel movements, and bladder, like all three of those.
Yes,
Okay.
yes.
So I feel like when we are, I talked about anatomy, right? I talked about how well can you lift, how well can you lower. The other thing I didn't talk about when it comes to continence, because I know Dr. King-Mullins helps with fecal leakage as well, not just constipation. So we want to know if you can lift, we want to know how well you can close the vaginal canal. So when I'm cueing someone through any kind of kegel, I say, can you pick up a blueberry? So can you pick it up and close and lift? And so we're looking at different layers of the pelvic floor. Can we close and lift? How well can we stabilize the organs? How well that can give us a good clue on how continent you are. Like, are you leaking or not leaking urine? When people struggle with that closure and lift, they're typically having hypermobility of the urethra and then they're leaking. So that's more of the bladder piece, and can then be at more risk of potentially prolapse, which I also think is a big connective tissue issue with childbirth. So, and then with intercourse, if you've got a trigger point, which I know Dr. King-Mullins picks up on those quite often in the pelvic floor, a trigger point, I always talk about, everyone can probably touch their upper trap and you get a tender point there. And it can sometimes refer down your arm or up into your jaw. Same thing on the pelvic floor. We don't typically feel pain inside the pelvis, but typically people are going to feel a trigger point referral pain into their bladder, vulva, testicles, penis, hip, SI joint. And so during intercourse, particularly penetrative intercourse, if there's trigger points, it can create this deep achiness where it just doesn't feel good around the pelvic girdle or any of those places. And then again, with constipation or having healthy bowel movements, we talked about range. So if you've got a lot of restriction and then you're just doing kegels because that's what you've been told to do because everyone's told to do them, you're feeding more into your dysfunction. And so that, you're doing all the things Dr. King-Mullins is telling you to do for the hemorrhoids piece, but you can't relax fully because you have a high tension pelvic floor, then that's going to create dysfunction with having a comfortable bowel movement and also emptying your bladder fully. I didn't talk about prolapse, but
Yeah. And so those are great points. And so some of the ways that I may relate this to patients when when they don't really understand what we're trying to get at, especially when a lot of their inability to move their bowels is created by a lot of tension, is just using the analogy of like PTSD, right? So I say like, hey, if you had unfortunately, a bad car wreck or accident at a certain intersection, every time you pass by that intersection, you may inadvertently clench up.
yeah,
Like you don't, it's something that's reflexive, right? And so even if you hadn't, had a childbirth or any other, had a vaginal delivery for men or women, if they've had a rectal surgery or if they've had an anal fissure from constipation that causes so much pain and
yeah,
trauma at the time of a bowel movement, now they're at the point where they're just like their body just automatically tenses up when it's time to have a bowel movement, when the
yeah,
sphincter muscles are actually supposed to relax and open so you can evacuate. So there's a lot of mindfulness that goes
yeah,
into, the whole process of evacuation if it's an area that's been traumatized chronically, or even if not chronically, if the issue was just so severe or so
yeah.
painful, it's just, an automatic reflex. So can you talk about things like, the other alternative treatments like the biofeedback and all of those things again, for those patients who um, they don't necessarily have something that we need to surgically repair, but they just need to restore their um, habits around toileting or evacuating and things like that.
Yeah, I'm so glad you brought this up because I'm talking strictly about the pelvic floor. But when we talk about the somatic response to stress, the parasympathetic and sympathetic nervous system houses it feeds all of our visceral organs. And so, including our bladder, our bowel. And so like a stress response, just like Dr. King-Mullins, whatever it may be, whether it's just having one fissure ever. I had a client with hemorrhoidectomy, and it had that itself, like the hemorrhoid needed to come out, but the procedure itself created her so much tension there. So when we talk about alternative therapy, I was talking very specifically in pelvic floor therapy about pelvic floor, but we talk a lot about the nervous system in here. And we have more time with clients to really talk through how to calm down their nervous system, right? So positioning is really important on the toilet, which I'm sure Dr. King-Mullins talks about this. How are we positioned? How are we sitting? We talk a lot about in here breath work. Breath is not only important for our nervous system, but I always talk about our body has 5 diaphragms. So there's one at the top of your skull, top of your mouth, in your throat, your breathing diaphragm, and your pelvic floor, and they all work together. And so we talk a lot about how do we breathe if we've got to bear down, what kind of breath do we need to use? So defecation is really important when we're pooping, that we're not clenching and holding everything tight, because if I'm doing that here, I'm also doing that in the pelvic floor. So positioning, how do you breathe through that? And then when we talk about sympathetic, parasympathetic nervous system, and I always talk about it a lot. I know Dr. King-Mullins talks about it probably quite a lot too, but it's that fight or flight. So we're constantly in a sympathetic state of arousal. And so I always tell people when we're going pee and poop, like that's your meditation time. Like no one's in there. Take your time. Don't sit too long when we're trying to poop, but like breathe, deep breathing, long exhales. That's going to down regulate the nervous system, bring in your parasympathetic activity, which is really important for that bowel movement. So that's, we're doing a lot of breath work in here, but we also talk about vagus nerve stimulation. So that's a lot of how do we trick your brain, even though you try to change your thoughts to calm down, how do we use vagus nerve stimulation? A lot of that's humming, breath work, vibration, cold therapy. We do auricular therapy, TENS unit. And so we use TENS unit on the ear sometimes for vagus nerve stimulation. And then also we use TENS unit for helping around the sacral area. And the TENS unit itself is externally, not the procedure that Dr. King-Mullins says, but that itself can talk to the nerves in the pelvic floor to get things to calm down. We don't do a lot of intrarectal bowel feedback for the population we see here. We find that in our sessions, that's enough feedback. So when we're doing our internal assessments, particularly interrectally, we're trying to get individuals to, all right, lift and then fully relax and connect with your breath. Those are some of the more alternative therapies, not so much from a modality standpoint. There's not a ton of modalities we use besides, I can't forget dry needling. Dry needling is
Yep.
fantastic. Dry needle alone and the dry needling the pelvic floor or the sacral area can help rewire things without your brain having to do it.
Yeah. So many tools that we
Yeah.
have. And I'm glad you kind of talked about kind of the whole rewiring your brain process. And so a lot of my conversations with patients are like the I know like a lot of people refer to the restroom as the throne, or when I was growing up, my dad called it the library and he would take his newspaper in there. Yeah, fun fact. But that is not your mobile office, okay?
Mhm.
So, it's not the place that you need to multitask. And so people, when this digital age, we have phones and all of these other things, these distractions, people get so used to, I wake up, I have my routine, I have a bowel movement, and then I go up, get up and go. So they want to lump things together, right? To save time or multitask. So they may go into the restroom, bring their phone in there with them. So while they're waiting on that bowel movement to get ready or something like that, they have their phone plugged up and they're responding to emails or doom scrolling and all of those things. And by the time, you look up, you're like, you've been sitting on the toilet for 20 or 30 minutes. That is not good.
Mm-mm.
Leave your phone outside. When it's time to use the restroom, don't force it. Don't push really hard. If you try to go and it's not coming, get up, move around, do something else, and then come back. You need, more mindfulness and kind of focus on the task at hand.
Mm-hmm.
Um, so I'm actually going to pause real quick. Sonia is our mediator in the background right now, and just to find out, have any specific questions come through or
Yeah.
comments based upon the conversation thus far?
Absolutely. Yeah. Actually, there's one question that came over from TikTok. I put it in the
Okay.
chat, but it says this question is for Dr. King Mullins. Are there symptoms that make you think this patient needs pelvic floor therapy, not another medication?
Yeah. Oh yeah, all the time, all the time. And it's the physical exam, right? And so, well, it's both of them together. So we call it the hallmark of an initial assessment of a patient is the history and physical. We talk to the patient. So the patient says, oh, they have constipation. And like I said before, like, what do you mean by constipation? You don't have the urge to go, or when you sit down to go, you can't get it out. And then so when the focus is more so, I have the urge, but when I sit on the commode, I'm pushing, pushing, pushing and straining. So then, you know, basic physical exam. Rectal exam and I say, hey, push like you're trying to have a bowel movement. And so if things are spasming shut instead of opening up for you to evacuate, or if I feel like all the weight of your pelvis kind of pushing down against my finger, that is that pelvic floor kind of just compressing down and not allowing you to evacuate. And so there's no medicine in the world that's going to fix that. However, there are dietary modifications that can help that because one of the things that people assume is that when it's difficult to push to have a bowel movement, they think that they have to make the bowels softer. They think that that whole concept of constipation, right? And so they do all these things, stool softeners, Miralax, this and that, to make it softer and make it softer, and that makes it worse. It is actually counterintuitive. So, again, I'm the queen of analogies because I got to make you understand so you can, number one, trust me, but really understand physiologically what's going on. So when you get to the end of that toothpaste tube and you're trying to squeeze out that last bit of toothpaste, that's like trying to make your bowels too mushy. You're trying to squeeze and squeak that out. While as when that toothpaste tube is full, you just push a little bit out of the back, and guess what? All this toothpaste comes out, and you're almost like, whoa, whoa, that's too much. And so the answer is actually to make a more firm, complete bulked stool so that when you push a little bit, when it kind of breaks the surface or entrance of that sphincter muscle, now it's more whole and formed and it all can come out together. And now you're not trying to squeeze or squeak out that residual kind of mushy. So when we're saying dietary modification because we need to change the consistency of your bowels, we're trying to change the consistency of your bowels to have better control. And one of the things I'm going to ask Dr. McGowan next is actually to talk a little about incontinence, kind of the other side of things, because again, a lot of it relates to the texture of your bowels.
Mhm.
It's easier to hold a rock than mud than water. So if your stools are too loose, it may be too hard for your sphincter muscles to hold that back. But when it's more firm and solid, your body can more detect it and control it.
Yeah.
So, so Dr. McGowan, can you talk a little bit about the process of evaluating, incontinence and what are some of the non-surgical treatments that you all offer or provide to kind of help with patients that can't control their bowels?
Yeah, yeah. So we'll do a bowel diary in here, and I'm sure you might do one as well. We're kind of looking
Hmm.
through it. You said it right. Like you can't have it too loose. We're not meant to hold water back through our anus. Like I always say, even kids can't hold that in. Like that's not what our sphincter muscles can do. So we talk a lot about, obviously, we're coaching through finding what fibers work. That consistency part is incredibly important. And so we'll coach people through that. And then obviously some clients just have a really disturbed gut flora and trying to get them to you and then to another provider because collaborative care is incredibly important. But when it comes to the incontinence part, I talk a lot about the stool sample reflex. And so sometimes people think they have to go and they don't have to go. And do we need to delay it? Are you sitting on the toilet too long? Because we'll talk, and some people will be sitting for 30 minutes to push that last bit out. But if you've got fecal incontinence, which I always like to bring this fact up, it's not great, but we go through menopause, estrogen changes, and at the age of 45, we have flatulence or we uncontrolled gas passes. And so estrogen receptors support our sphincter. It's incredibly important. And so that's not fun as we're aging. But then also the leakage part, excuse me, if we are having too loose stool, like again, people will pass that through these that can't hold it back. And during our assessment, we found if we found in the clinic that their sphincter muscles themselves during an intrarectal assessment are weak, we've got to work on strengthening that. We know it takes 8 weeks to build up strength. So, so there's that piece from the pelvic floor. TENS and dry needling can help again, kind of wake muscles up a little bit to stimulate them so that you can find those sphincter muscles and the deep pelvic floor muscles a little bit more as well. So the leakage part we find for fecal incontinence, they're almost always having urinary incontinence. I don't know if you find that as well. So it's going to take time to build it up. And then again, like really go deep dive into like, what are we eating? Are you eating because people think that you think that you're doing it, but when you journal it, you're like, I'm actually getting
Hmm.
8 grams of fiber in.
Yep. Yep. So we call that recall bias. And so I
Nice.
will take it a step further. So, so I ask people like, hey, what's your diet like? Oh, I eat pretty good. I try to avoid this and I try to avoid that. And I'm like, oh, okay. What'd you have for breakfast today? What'd you have for dinner last night and the day before? And then you're like,
Hmm.
I know you try, but you just listed that you are not following anything that you said you thought you were doing. So that's
Yep.
recall bias. We assume we're doing better than we are.
Yep.
Okay. Um, so that's the first and foremost. So just like you said, doing the journal and just keeping yourself honest to understand what exactly is going on. Um, but then when we talk about incontinence, again, it's one of those things you have to distinguish because there's so many terms that are thrown out there that we really have to take a deep dive into what patients are experiencing or what they mean.
Mhm.
So, a lot of patients will come in and say they're having incontinence or leakage. And so I ask them, when are these instances occurring? What's the consistency? Like, are you talking about you can't control your gas? Are you talking about you can't control your urine? Um, is it that you feel the bowel coming and you can't hold it back, or you go to the restroom and look and oh my gosh, there's stuff in my underwear and I don't, know what that is and how long it's been there? And so there's the incontinence part where you just can't control it, feel it, or hold it back. But then there's that leakage that can happen with other pelvic floor issues like the rectocele. And so that goes back to the consistency of the bowels, because if it's too soft and you're kind of push, 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 straining and squeezing, and you're not completely evacuating, over time, once you kind of relax that area and things are kind of, ah, now things that you couldn't get out may leak out. And that's not quite like true incontinence. That's just kind of a little bit of leakage or spillage that may be a little bit residual. And so that's treated a little bit different if it's caused by a rectocele. But again, our first and foremost, kind of fight in this battle is addressing, what the texture of the bowels are, because nothing is going to last forever. You may do the best job that you can on strengthening that pelvic floor, and I may, do the best job at fixing and nip tucking whatever. But, our bodies are our bodies over time. The composition of muscle mass to collagen and elastin and the adipose or the fat cells, they're going to continue to change. Our hormonal levels are going to continue to change. So, I mean, aging is a process. And so, no matter what happens, no matter what type of interventions we can provide now, some of that, there's going to be in the future probably some return of symptoms, some further dysfunction that happens. And so we have to make sure our patients have like the core knowledge of understanding how their diet also plays a role, no matter, what we do. So I want to take a quick pause and say hey to everybody again who may be joined a little bit late. Dr. King-Mullins talking with Dr. Jennifer McGowan of Regenerate Physiotherapy, our pelvic floor physical therapist. And yes, there are physical therapists specifically trained to help you work on your pelvic floor. Those are muscles just like anywhere else in your body. So if you have a dysfunctional neck, back, leg, arm, whatever, and they send you over to physical therapy, there's muscles down there that train you or not train you, but there are dedicated teams of professionals that are designed to help train you restore any dysfunction that you may have after surgeries, childbearing, chronic constipation, you pushing and you wore out those muscles, or something, anything going on. So they
Mhm.
can definitely help.
And
Sonia, do we have any more
yep,
questions in the chat?
I do. I have one from Facebook. It says, so what are some things people unknowingly unknowingly do every day that actually make pelvic floor dysfunction worse? So I know you all talked about poor toilet habits, maybe straining, but this is even a question for me. I've been told, obviously, sitting with poor posture can possibly make things worse. So I just love to hear your thoughts on that, Dr. McGowan.
Go ahead.
Yeah, yeah. There's a lot of pelvic floor muscle dysfunction that can exist and symptoms. So I would say a couple things that I haven't had the opportunity to talk about is intra-abdominal pressure management. So how we handle pressure in our abdomen does affect our pelvic floor. And so if you're doing, anyone listening or will listen in the future, if you're doing any powerlifting, advanced core work, and you've given birth, and you haven't had your pelvic floor assessed, I would highly do that. I think that it's great as women, as we age, we continue to lift heavy and we continue to do high impact exercise to help our bone health, cardiovascular health, nervous system health. However, if every time you're lifting heavy, you're bearing down, you're bearing down, you're bearing down, that could put you at more risk for leakage and prolapse. So if you're lifting heavy, awesome. But if you leak at all, I always tell people, if you leak with cough, laugh, sneeze, and it usually starts urinary and then it can switch to fecal leakage, that's leakage. And so people, it doesn't just get better on its own. So really investigate. If you're listening to us, like, am I leaking? If you are you? A lot of us are constipated. So many. So
Yeah.
I think lifting and how we breathe, if we could make things worse in that way. We've talked a lot about how we're pooping and peeing. Yeah, if you're bearing down a lot, that could put you at more risk. And so that's another thing to really consider when I'm peeing and pooping. Like, am I pushing my pee out? We don't really need to push our pee out. We just need to relax. How much am I
Yep.
bearing down? That could be a problem and more risk for prolapse or pain in your pelvic floor. Sitting, not really. I think of sitting globally if people are, if you're gaining weight and you're sedentary and you're not moving, like, everything is affected in the body and including the pelvic floor. We know research tells us that increasing weight, our weight will, increasing weight or gaining weight rather, could put you at more risk for urinary incontinence, not so much prolapse. So, but sitting in general sitting can affect tailbone pain and hemorrhoid discomfort.
Yep.
So we all need to be moving for a lot of more reasons besides our pelvic floor. Outside of that, not a whole lot. I think, and I know Dr. King-Mullins has this conversation a lot of this is preventative. I wish and this is not a birth talk, but we don't have a lot of support around vaginal birth and how to do that, being coached to that. Doulas are incredibly important. If you're thinking of getting pregnant or are pregnant, like, having that support about how to push and being supported in your environment, because I think tearing, all of that is, and I know Dr. King-Mullins sees this and I do, it's that I had myself, I had, I had twin birth, 3 perineal lacerations. So I think a lot of the pelvic floor is preventative through time. And so making it worse, not so much, but I just think every woman needs to have the pelvic floor muscles assessed at some point, especially if you're listening and think you have a thing going on. Because if you catch it now, we prevent it from surgery,
Yep.
potentially down the line. And our estrogen leaves our body and that changes our tissue health. And so it makes it hard for great repairs to last forever.
Yeah.
There's that.
So a couple of comments on that, though. That was a great, discussion. So first and foremost, I know, so pelvic floor physical therapists are hard to come by, and thank goodness we have so many more now available than when I first started in practice 12 years ago. Um, But, I do have some, OBGYN friends who are just like, man, I wish every single woman who has, carried or delivered a child could have at least one, pelvic floor, consultation. And so, I understand because there is, a paucity of pelvic floor rehab therapists, there may be a lack in adequate coverage financially in getting those services. And so a lot of times I will tell my patients, like, hey, if you can, at least have the initial consultation. You may not be able to commit yourself, logistically or financially to the long haul, but at least getting in and getting that initial assessment to understand what's wrong, getting a nice thorough examination and recommendation on some great homework that you can do, direction on maybe even some exercises or videos or online, that can take you a long way as opposed to not doing anything, at all.
Mhm.
First and foremost. And then the follow up on Sonia's question about, how sitting may impact the pelvic floor. So while it may not weaken the pelvic floor in general, there are some things about chronic pain that can occur. And I see this more and more as we go further and further down the line of more remote work and more sedentary lifestyles. And so long term and prolonged sitting, if you're not maintaining the appropriate posture, can affect bowel movements or hemorrhoids or rectal pain because there literally is a muscle that attaches to the tailbone and wraps around the rectum. And so, if you sit a little bit too relaxed with kind of laid back with pressure on the tailbone, over time that pressure can impact that muscle spasms, and it starts tugging on the rectal muscle, and you can have that pelvic. So, a lot of times people think they have rectal pain because it's just tugging on that muscle. So, you do have to sit more kind of upright and right and square so that the majority of the pressure is on the upper part of the hip and thigh and not relaxed on your tailbone. And so that can help long term, even with how you move your bowels. Because again, if there's a lot of spasm that happens when you go push to have a bowel movement, that pain and things spasm shut, that can force you to have to push a little bit more and contract a little bit more and can cause some pain. And so if you might be experiencing that, maintaining your posture, ibuprofen or some sort of anti-inflammatory can help with that pain, and then doing some stretching exercises. So that kind of pelvic stretches, and then as well taking a nice warm tub bath before bed can also help, restore that blood flow to that area and kind of make it feel a little more comfortable. Um, so our last and final subject that we're going to get to, because I'm man, like we'll have to have you back, Dr. McGowan,
Ah,
because
Yep, because there are,
too much.
it's
yeah, there are
insane.
like three more questions, just so
Yeah,
you know.
and we'll try to get those, but I
Yep.
definitely want to touch a little bit about pelvic organ prolapse. So we talked about that hammock, the vagina can bulge, the bladder can bulge, the rectum can bulge, and so once those kind of orifices and spaces kind of widen. So talk a little bit about what pelvic floor physical therapy can do for pelvic organ prolapse or rectal prolapse, bladder prolapse, vaginal prolapse, and kind of how you manage those for especially for patients who may not desire or may not be good candidates for surgical intervention.
Yeah, so I say we can't necessarily fix the prolapse. That is a structural thing typically, but we can help certainly with prolapse symptoms. And so a lot of that's going to be, again, there's several different types of prolapses. And so depending on the one we have, we've got to figure out, again, what's going on with the pelvic floor. We talked about the evaluation quite a bit through this. So what's going on coordination wise, what's your strength wise? For some clients, you got to not work on strength, but how well can we lengthen? We work on lengthening, bearing down. Dr. King-Mullins talked about my biggest thing when I talk about opening the pelvis is your hips and your glutes are your pelvic floor best friend. So anything where you're opening up the hips and relaxing that's going to relax the pelvic floor. The other thing I didn't talk about is pessary fitting. So pessaries can be really, really helpful for prolapse symptoms in combination with pelvic floor PT for trying to avoid surgery. I find that certain types of rectoseals not so effective, but if you're having, again, prolapse symptoms, I always like to repeat because I know we talk about it all the time, but prolapse symptoms, typically the biggest thing is you're going to see or feel a bulge. So you got to look at your vulva, you got to get a mirror out and actually look. If you've not looked, you may feel it when you're in the shower, a bulge, or it's like there's a
Mhm.
tampon there, something's there, there's pressure. Prolapses can sometimes be painful. So with the prolapse symptoms, I always want to know, when are we feeling it? Some of our clients feel it just when they're working out. Some of it feel it at the end of the day. So we talk a lot about how can we manage those, make sure we're peeing and pooping appropriately, pessaries are, I always, again, Dr. King-Mullins knows these really well, but they're devices that go intravaginally. They can be cubes, they can be rings, they can be cups, and they're fit specifically for your pelvic cavity. And they're medical grade silicone that we fit here in the clinic. So those are ways that we help, and we typically help pretty quickly with prolapse symptoms. And we'll have clients not need surgery for a long, long time if they ever do. Some clients end up after 3 or 4 years needing to do it, but that's kind of covering the bases on our end with. And there's also
Yeah.
things called pelvic bras. You put compression externally if you don't want a pessary for prolapse
Yeah.
symptoms. Hmm.
Yeah, that's a great, and those are great, kind of bridges sometimes to patients who they're like unsure if they want surgery. They're absolutely like opposed to surgery or like, hey, maybe just not now. And so having that evaluation and that option available is always there. Um, and I will make a special comment right now um, about pelvic floor prolapse and dysfunction in patients who may not fit the traditional mold. And so a lot of the discussions we're having are about, patients who have some sort of either pelvic floor trauma, so pregnancy, delivery, surgeries. But in a relatively young, healthy patient who has not had any of the trauma that we're talking about, and does not necessarily battle with chronic constipation, pelvic floor prolapse, bulging, piques a special interest and needs further evaluation. So while they likely will need pelvic floor physical therapy and often they will likely need some sort of surgical intervention, they need a further evaluation for certain entities to understand why their tissues aren't holding like they should when they haven't had trauma. So,
Yeah.
mixed connective tissue disorders, Ehlers-Danlos syndrome, collagen deposition disorders, elasticity disorders. Like if you're double, triple, quadruple
Yeah.
jointed, right? Like, that's not always
No.
the best
Yep.
mean. That may not be a moneymaker for you to get in Cirque du Soleil, okay? That might cause other problems.
I,
And so, so please, if that resonates with anybody that's listening, while again you may need surgery and may need Dr. McGowan or my help, I think there's some other underlying things that you may need to make sure you get evaluated for because some of those diseases can affect heart, can affect lungs, your respiratory function, like so many other things. It can predispose you and make you at risk for other injuries and more serious things that can go on your body. So again, if you haven't had any, major trauma or things that should impact the pelvic floor and you're having a lot of pelvic floor dysfunction, make sure you seek out and advocate for yourself to get some more answers as to why that may be happening. Um, so Sonia will be able to entertain a couple more questions.
Okay. Darlene is asking, can you have pelvic floor dysfunction due to diverticulitis?
Usually not, unless you've had a surgery that has really impacted the pelvic floor. So while diverticulitis traditionally affects that last part of the colon before you hit the rectum, the sigmoid colon, if patients have had some of the complexities of diverticulitis, so if they had a fistula to the vagina or the bladder or something like that that requires some other surgical reconstruction to that pelvis to get rid of that diverticulitis, but just in and of itself, diverticulitis should not impact your pelvic floor.
Okay. And then I have one that says, do you ever see patients who thought they had digestive issues or even feared colon cancer, but it actually turned out to be pelvic floor dysfunction?
Yep, all the time.
Wow.
All the time. And so, if again, when we talk about that, it's really important to hone in on the specifics of a patient's symptoms. And so, I can't reiterate enough, we often get that symptom of constipation, but they really may be meaning that they can't evacuate well. And so if they're not evacuating well, someone may think that, especially if it's an older woman, they may think, oh my gosh, you have a colon mass, you have a blockage, you have an obstruction, and that's what's preventing you from being able to have a bowel movement, where it may be that pelvic organ prolapse or everything's kind of, really pushing down and not allowing you to evacuate. And so that can instill a lot of fear in people, right? If they think something's truly like there's some sort of mass or something in there that's blocking their bowels, that can, elicit quite a bit of anxiety and concern. Jennifer, you want to answer that question as well? Or anything that you've
Um,
seen?
Repeat the question. I was so much
Sorry.
listening to you. I'm like, yes.
No,
That's okay.
yeah.
It was, do you ever see patients who thought they had digestive issues or feared colon cancer, but it actually turned out to be pelvic floor dysfunction?
Yeah, I was like, this is totally king. Because so for us, that isn't a direct concern, but they've been, what we end up getting on our end here in the clinic is they've been to everyone, not Dr. King-Mullins typically. They end up with her and then like, oh, she sent me this week because they've been through all these tests because they're fearful and they're having this pain and rightfully so. Colon cancer is not a great thing to have and on the rise. But we often hear we get all these bad things ruled out but they're still left with their symptoms. And so we get the other round of they've gone through all the testing and they can't believe they never heard that pelvic floor therapy exists.
Yeah.
In our end, if I'm seeing someone directly and I'm suspicious about anything, I'm like, you need to get to a GI doc or see Dr. King-Mullins to make sure, especially with any bleeding and all those big signs. So on our end, if you've been someone out there like gone through all the tests and everything's clear, I would consider getting your pelvic floor muscles assessed.
Okay.
Great. I've got one more
And that's
question
it.
on my end.
Sure.
It says there's a lot of talk about pelvic congestion syndrome, more than I've ever heard before. Is there any relation to that with constipation or bowel issues? If so, how would you know?
Good question.
All you. All you.
Great question. So thankfully, pelvic congestion syndrome is being diagnosed more. So a lot of what pelvic congestion syndrome is, and we talk about all the functions of the pelvic floor, there's a lot of lymph vessels and veins and arteries that go through the pelvic floor. And Dr. King-Mullins did talk about connective tissue disorder. What we're finding with clients that have connective tissue disorder may be at a higher risk for pelvic congestion syndrome. For me helping clients, pelvic congestion syndrome and pelvic pain kind of overlap. Symptoms overlap rather. And so oftentimes we do get referrals here in the clinic with clients that have had all of the stents for pelvic congestion syndrome and things feel better, but they're still feeling pain. And so often if you're having, just like we talked about at the beginning, if we're having pain during a bowel movement, we're not like our sphincter, our poor sphincters just hold so much of our stress all day long. We're just
Hmm.
clenching our buttholes. Sorry, like just clenching. So if you're having pelvic pain with pelvic congestion syndrome, people feel there is swelling into the legs, but oftentimes when there's any kind of pelvic floor dysfunction or constipation issue, it's because typically what I've seen for the clients that have come here is there's pelvic pain. And so they're having pain with bowel movements. So if you've been diagnosed with pelvic congestion syndrome and you've gone to see a interventional radiologist for treatment, that's your typically gold standard, and you've had the treatment, but still symptoms. Again, there could be prolapse going on and you've not been assessed. So Dr. King-Mullins and myself could assess for that. Or there could be pelvic floor trigger points or neuralgia in the pelvis that isn't being resolved with stent procedures. You have anything to add to that?
Yeah, and I'll just take it like a slightly a step further, especially with some of the patients that I deal with who may, with rectal cancer or anal cancer, who may have had radiation to the pelvis, or they could have had radiation to the pelvis for a gynecologic cancer, like a vulvar or a cervical cancer. Sometimes they can develop what we call as lymphedema, which is along kind of that spectrum, and so they can have that kind of pelvic congestion and chronic swelling and pain. And so they may also benefit from the services of Dr. McGowan with some of that pain and just kind of reprocessing and exercising of those lymphatics to kind of
Yeah.
reprocess that fluid.
Yeah.
So yeah. Oh my gosh, this has been such an amazing
Yeah.
conversation, and I think we definitely have to figure out a part two. Um, so I'm Dr. King Mullins, also known as Dr. Tissue Touch Up. This is Dr. Jennifer McGowan of Regenerate Physiotherapy. She is a pelvic floor rehab therapist, a specialist. There is someone out there who can help you if you have chronic pelvic pain, rectal pain, spasm. Like, there's so many other things. So when people say, oh my gosh, it's all in your head, it may not be. So you may have had CT scans, MRIs, ultrasounds. They've said, nope, it's not fibroids, it's not endometriosis. Nope, it's just all in your mind. It really may not be, especially if you've had any surgeries in the area. If you've had or delivered children, that changes your whole physiology, that changes your whole anatomy. And so, just like we get support with damage to tissue structures anywhere else in our body, our pelvic floor rehab therapists are here to help with realigning and readjusting the physical changes that can happen. That may not be able to be surgically repaired. Dr. McGowan, do you have any kind of closing remarks, pearls, tips, or tricks for anyone that's listening in?
I just love that you mentioned like listen to yourself, and if you've been medically gaslit, I don't know how we want to say it, it exists,
Yep,
and
that's
if
what it
you
is. Yep.
it exists.
Hmm.
So trust your intuition. If you're having symptoms, like that's real, and find your people. The people are out there. I know that someone asked, is there a pelvic floor therapist in Detroit? Pelvicrehab.com is a great search engine for any pelvic floor therapists around the world. So if you're wherever you're listening in, looking for a pelvic PT there, on that website would be fantastic resource for you. And thank you for having me.
Yeah, thanks for that. Thanks for that. And so, yeah, and do us a favor with that resource, just if you can post a little something and tag us in it so we can just make sure that those folks that are listening, I think we're going to be posting this, we should be posting this on YouTube too. And so we can put that in the notes just so people can definitely know in their areas how they may be able to get a little bit more information and access because it is tough. Like I said, when I started in practice 12 years ago, I mean, I could count on one hand the number of pelvic floor physical therapists that I can send to, and they were all like central Atlanta. And so
Yeah,
now it's definitely, so now they're like, that didn't really help me down 30, 40 minutes south of Atlanta. And so
yeah,
now we
absolutely.
definitely have, some folks that are really dedicated. Dr. McGowan has been amazing. The just reciprocity that we've experienced with some of our patients, it really goes a long way because orthopedic doctors work with physical therapists
I
all
know.
the time, right? And so we as colorectal surgeons that work with the pelvic floor, we need to work with physical therapists more because that's a whole nother structure that needs support after, it's been injured. So,
Yeah.
yeah. All right. Well, thank you so much. It's been a wonderful night. Thanks, everybody. Post any additional comments or chats, DM us, let us know, and we'll follow up as best we can.
All right.
Bye
Thanks
for
all.
now.
Bye.